Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM and 1080 AM. And you might be listening through your search engine. And if you are, good morning to you. And my name is Francesca Messiah from Kaleida Health, Manager, Workforce Development, and your host for today's hour-long program on the Great Lakes Health Radio show. A little bit about Kaleida. Who is Kaleida? We're the hospitals. Which hospitals? We're Buffalo General Hospital, We're Gates Vascular Institute, Oishei Children's Hospital, Millard Fillmore Suburban, we're DeGraff Medical Park. We're also the Visiting Nursing Association, the VNA, that is a service that does home care visits for all ages, 24 hours a day, 7 days a week. We also have clinics located throughout Buffalo, throughout the North Towns and the South Towns. And we have clinics for adults, clinics for women who are expecting children. We have clinics for teens, and of course, our children. We have clinics for children. And I have to say, all of our clinics, especially the ones in Buffalo, are all located on a bus line. Also, I want to mention that Kaleida is hiring. Come grow with us at Kaleida Health. For more about jobs at Kaleida Health, please visit Kaleida Health. That's KALEIDA HEALTH /careers.org. And there you will find hundreds of jobs. Some jobs require a high school diploma or a GED. Others require a PhD, and we have everything in between. Remember, hospitals are open 24 hours a day, 7 days a week, and we need all kinds of skills and skill sets to maintain our facilities. Also, we're available for outreach and with job fairs, especially with job fairs. Also, we're doing health fairs, but job fairs is what we're also now doing that. And if you're interested in any of our past programs, we have at least 5 years worth of programs that you can use for your business, your school, your classroom, your church group, your faith community, and they're available for you to use. They're all factual. All righty, on with our show. Well, November is, you know how each month there are areas in healthcare that the community and the country focuses on. Well, November is Lung Cancer Screening Month. And today on our program, we have Dr. Yukon Perry, and he is the Chief Division Thoracic Surgery, Clinical Professor of Surgery, and UB Director of Thoracic Oncology with the Comprehensive Center within Great Lakes Cancer Care Collaborative and Kaleida Health. Welcome, Dr. Perry. How are you?
Good morning, Francesca. How are you? Thank you. Thank you for hosting us, and thank you for all the work for the upcoming November for the Lung Cancer Awareness Month.
Thank you. And also on the call, we have Megan Batista. Megan, what is your title?
Hello, Francesca. My title is Oncology Nurse Navigator. My role comes into play once a patient is diagnosed with cancer, and I help to navigate them through the healthcare system and address really anything that is going to prevent them from receiving care.
Yeah. Oh, which is so important. We need you. We need that. We need that service.
Yeah.
Okay. Well, I'm with the program. And Dr. Perry, could you just tell us a little bit about what is lung cancer, and most importantly, what are the warnings?
Definitely. So lung cancer obviously is cancer that comes from the lung. This is the second most common diagnosed cancer, both in men and women, but it's actually the most common cause of cancer death. It's the leading, it actually caused more death in the last year, more than breast, colorectal, and prostate cancers combined. The burden of lung cancer is significant. We all know that it caused from cigarette smoking, and obviously the symptoms are when it's advanced, the symptoms can be cough, coughing blood, weight loss, shortness of breath. But I can tell you that unfortunately or fortunately, the most common symptoms of lung cancer is having no symptoms.
Really?
Because when you have lung cancer, when it's very early, this is the time we can cure it. But when you have symptoms, meaning, let's say someone has lung cancer, that the cancer itself is replacing the lung tissue and growing to the effect that actually invading into major vessels and cause bleeding when the patient coughing blood, well, that's unfortunately, it's too late. It's probably beyond cure. Another issue is when you short of breath, it means that the cancer is occluding the air pipes or causing replacement of the lung tissue to the effect that the patient has no more lung to breathe. And this could cause shortness of breath. So these are very advanced stages of lung cancer. So we hope that most of our patients with lung cancer, if God forbid they develop it, will find it early before they have any symptoms.
That's interesting. You know what? Could you just say, you said something about the cancer replaces, what does it replace in the lungs?
The lung, basically the lung tissue. The lung, we use our lungs to breathe, right? He has the special units that help to change, get the oxygen in from the air and get the CO2 out. But when it's replaced by tumor cells or by cancer, when the normal lung does not exist anymore and the patient basically feels short of breath, and it's sometimes too late.
Okay. Well, you know what? I'm always learning something new with this program. And so that's new. Thank you. What percentage of people in the US have lung? I know you said it was the greatest cancer, but is a percentage, let's say in Western New York, any higher than the percentage of people in the US who have lung cancer?
So, I mean, I don't think that New York is special. It's one of the highest area, but if you think about, there is an estimate this year, the American Lung Association and the American Cancer Association actually both estimated about almost 250,000 people. It's about half and half men and women who are diagnosed with lung cancer. And unfortunately, half of them, about 125,000 people to 127,000 people, will die from this disease this year. So it's really, really endemic, and it's significant. We have, if you look about patients who had history of lung cancer, we have more than 500,000 people, 654,000 people, women and men in the US had history of lung cancer. Many of them actually living with metastatic disease, and 80% of them were 65 years and older. So we see significant amount of patients in the US with lung cancer. I hope that answers the question.
Yes, yes, it does. And I also want to apologize because I mispronounced your first name, and it's Yaron. Is that how you pronounce?
Yaron Perry, yes.
Yaron Perry. I think I said Yukon and not Yaron. So I want to I wanted to make that that correction. Something that you just mentioned about age. So is lung cancer, I know from the reading, they talk about if someone is smoking a pack of cigarettes a day. So let's say they started, I don't know, I just pulled the number 15 out of the air. Are they any younger to develop lung cancer before age 65, as you had just mentioned?
Definitely. So, let's talk about statistics a little bit. So, 80% of the individual who has lung cancer are 65 years and older. But as you mentioned, it's really the function of how many cigarettes they smoke in their life. So we have a measure that if somebody smokes a pack a day for 20 years, they say they smoke 20 pack years. So if they start at the age of 50 and now they're 70, they have 20 pack years. But if they start earlier and they have 40 pack years, first, their cancer obviously can show up earlier, but also they are currently in much more risk of developing lung cancer than somebody who smokes less.
What if they combine cigarettes with vaping or cigar smoking because they really like smoking?
Well, I mean, anything that irritate the lung, and we can talk about vaping in another session, but definitely we don't have the hard data about it, but still we know that vaping can cause lung cancer, but it's accumulating. Any nicotine products or any cigarette smoke or cigar smokes can contribute. The difference is mostly that cigarettes are used much more frequently, and usually people who smoke cigarettes smokes much more than people who smoke cigars average. So definitely it's mainly accumulating. So the more you smoke, the more you increase your risk for lung cancer.
Mm-hmm. Now, let's talk about cancer screening. Lung cancer screening. If someone's listening to the program and they're coughing and have a difficult time catching their breath, they're coughing, and they're still having a cigarette, where do they begin to go for a lung cancer screening? What should they do? Can you walk us through the steps, please?
Right. I'll let Megan pitch in here.
Okay, so currently, in order to get a low dose CT scan for lung cancer screening, it's Medicare guidelines. Okay, so ages 55 to 80 with, is it 15 or 20 pack years?
20 years.
They have to have 20 pack year history. Unfortunately, we can't do younger, right? Because insurance is not going to improve it. And typically, it starts with the primary care physician, establishing a good relationship with them. There are so many people who don't want to be honest with their primary care physician or their other doctors because they feel judged. There's that stigma there. So unfortunately, that leads to less people being screened. If you don't have the pack years or the age, we still encourage you to really communicate with your doctor, so that let's say in 2 years, when you do qualify based on the criteria, you can get your screening. There are some health insurance companies that you can really advocate with and try to get those appeals in order to get those screenings, because it's just like breast cancer, prostate, colon, where early detection really does save lives. Because at earlier stage, there is a much higher chance of cure.
Could you just say what you call them pack years? And
Mm-hmm.
Listeners, our show today, we're talking about lung cancer screening, and I just want to make sure, because I don't quite understand what our pack and talk about smoking packs, right?
Yes.
Cigarettes.
So you multiply the number of years that a person has smoked by the number of cigarettes smoked per day. The number of packs, excuse me. So let's say you smoke half a pack a day for 10 years. So you'll multiply 10 by 0.5. So they'll have 5 pack years. Does that make sense?
Yes, it does. But you don't have to worry about doing the math. You would just tell your primary care provider, I've been smoking, I've been smoking since I've been 12, and I've been smoking a total of 3 packs a week, and they can do the math.
Absolutely. Yeah. Or you could tell them how many cigarettes you smoke a day. You don't have to do any calculations on your own as a patient. You don't have to think about meeting criteria. It's really the role. And you can share this if you have a pulmonologist as well, any of your healthcare providers. And for all of our doctors out there, I just encourage you to be supportive of your patients. Having this open communication, this non-judgmental relationship, it's super important for your overall health, right? You're going to be more honest about all of your lifestyle choices. And it's just going to lead to better care when you're honest with your doctor and when you feel you can be.
Mm-hmm. No, that's true. Go ahead.
And again, I want to make sure that everybody understands that the best way to cure lung cancer is find it early, meaning find it before you have any symptoms. And the only way that we can find it early is by having a chest CT. Chest X-ray is not enough. A chest CT, a low-dose CT scan, will find early lung nodules or lung cancer. And this is the one that we can actually remove surgically, there's other treatment. If people cannot have surgery because of other medical conditions, we can refer them to our colleagues from radiation therapy. They can do ablation therapy, but there's many therapies for early stage lung cancer, because in order to cure a patient from lung cancer, we need to find it early before you have any symptoms. So if you're smokers, if you smoke for 20 years, don't start to calculate. You need to talk to the doctor and you see if you're eligible for screening. And there are other ways to find a way to get somebody's CAT scan, not necessarily just for screening, especially if you have symptoms. But if you don't have any symptoms, definitely see if you're eligible for screening, because if you are and we find early nodules, it's already proven. The National Lung Study Trial already proven that lung cancer screening saved lives more than any other screening. Not more than screening for colonoscopy for colon cancer, more than screening for breast cancer. This is the best screening method that can save life and basically improve the longevity of patients who has lung cancer.
And just to piggyback off of that, for those folks who a lot of time patients are concerned about the level of radiation that they could get, a low-dose CT scan gives you less radiation than an X-ray. It's actually less radiation than just walking around existing every day. So it's not going to impact your current health by being exposed to the scan.
Okay, thank you. Prevention. We haven't talked much on prevention, and I've known people who have had lung cancer and they've gone for treatment and they're still smoking. The cancer comes back again. Why is cigarette smoking so addictive? And what can someone do who maybe doesn't want a screening, but they just or they want both? They want a screening, but at the same time, they are trying their hardest to stop. What information can you share with that listener?
I'll take that question as well. Number one, the person has to be ready and willing. I try to explore their smoking history when I'm working with them. What age did they start? Have they ever tried to quit in the past? What hurt, or what helped, what didn't help? I try to identify their everyday coping skills that they are already using, if they have any, just for everyday stress. And sometimes it's a cigarette and a drink. It's just about meeting the patient where they're at, and trying to grow from that. There are nicotine replacement products, there's gum, lozenges, patches. Sometimes patients want to go with that, which is great, but it's also about replacing that habit with something else. Sometimes my patients describe it as this period of grief. They've had this thing in their lives, this moment to take them away, to breathe, to fidget with, do something with their hands. It's a social behavior as well. So they have to kind of add something new into their lives to help take up that space. I encourage new hobbies, crafts, distractions. There's the 5 Ds: distract, delay, deep breathe, drink water, discuss. You can get, I think it's a month or 2 week supply from New York Quitline. There's also Zyban and Chantix, which a doctor can prescribe for you if you're interested in that.
That's gum, right? Is that gum?
No, those are both oral medications that you take every day. Yeah, it's supposed to help reduce cravings. And, it's not for everybody, but it's definitely worth a conversation if you think it's helpful. I encourage patients to change up their habits. A lot of times it's, the first cigarette of the day is with a cup of coffee. And you say, do you smoke it in the house? Do you smoke it outside? If they're in the house, maybe you try to go outside, because it's changing that behavior, that association, and maybe it's unpleasant. We live in Western New York, right? It's freezing. So maybe they want to have 1 cigarette instead of 2 with that cup of coffee. Or changing up where you smoke, right? Maybe you don't smoke in the car anymore. Maybe you only smoke in a certain place at a certain time. Any way to really reduce that. And it's okay if you make a mistake. there are ways you just start again. You have unlimited chances to stop.
Mm-hmm. Yeah, I've even known of people who have smoked a half a cigarette, then they put it out, and then they'll take it up, get it again. Is a cigarette? I mean, not to say, is a cigarette a cigarette? Does it matter? Is it any more dangerous, or if it's like the first half or the latter part of the cigarette? Does it matter, or is it all cancerous potentially?
It's all, yeah, potentially cancerous. It's harmful. It's also, the leading cause of COPD. There are other explanations for folks who could get lung cancer. There's chemical exposures. We have a lot of, radon. There's toxic waste burials, asbestos. It's still in a lot of homes, but it's intact, right? It lasts a long time. They're not in these industrial buildings where we're doing construction, but these are all contributors as well.
And also passive smokers, people that are exposed to smokers at home, or people who work in a bar or used to smoke there. It's also important. This can expose them to and increase the risk for lung cancer.
And I guess a casino, because they're still, even though they have non-smoking sections, you can still smoke at a casino.
Mm-hmm.
Yeah, I just thought about that. Now, lung cancer screening is a lung cancer screening then the low dose chest CT? Is that a lung cancer screening?
Yes, that's exactly it.
Okay. And then if someone has cancer, then is there like another screening that takes place after that, or what happens if someone is diagnosed with cancer?
So maybe so when somebody already diagnosed with cancer, this is different. It's really not a screening. It's called like a surveillance. We basically follow these patients for life, especially if they cured from lung cancer. Let's say a patient has an early stage, had surgery, for example, come to us and had robotic lobectomies. A couple of days, they go home. We follow our patients for a long time. We see them to follow our patient about within 2 weeks after the procedure when they go home. Then we see them 6 weeks after, 3 months after, every 3 months for the first 6 months, every 6 months for the first 2 years, and then yearly. And every time they coming with a low dose CT scan in order to make sure that the disease did not come. The definition of those, although you can call it, screening, but if somebody has already lung cancer, they will go for like a long-term surveillance after the surgery. And I think after 5 years, we go back to the definition of screening and not surveillance. But it's basically the same procedure. They're going to have CAT scan to make sure that they don't have recurrence of their disease or any new nodules.
So if one of our listeners think they have it, I'm not sure if I asked this question. Should they call you or go to their primary care, or where should they start?
Truly, what I recommend is starting with a thoracic surgeon. Every member of the multidisciplinary care team is important. So that would include our radiation oncologist, the doctors who would give you radiation, the medical oncologist who would give you oral or infusion medications for your cancer if needed, and the thoracic surgeon. The reason I recommend starting with a thoracic surgeon first is that our other two specialists cannot do anything without a tissue biopsy. When I say tissue, that is when one of our doctors, it could be a variety of specialists, they go into that area of concern where we think there's cancer. They take out some of the cells, right? And then it goes to pathology. And our pathologists, they get it under the microscope. They do all sorts of magical things to it. And they can say, oh, this is this particular type of lung cancer, because there are a variety of kinds, right? And that helps guide the treatment. So if there's no tissue, we just have a suspicion and they go to medical oncology, then they go to see a thoracic surgeon. You've already lost some time there. And like Dr. Perry has stressed, time is really of the essence. We have two incredible physicians with our group with Great Lakes, Dr. Perry, who's located at Buffalo General, and Dr. Kakish, who is located at ECMC. He's located in the Jonah Center. Our surgeons get the tissue. They can also order the PET scan, which is a whole body scan, which we, can certainly go into more detail with the patient if and when they need it. And they continue to do that workup. They can look at the DNA of those cells, right, of those cancer cells. And again, that's something that helps guide treatment. Nothing anybody needs to remember at this point, but just to kind of highlight the importance of why I recommend starting with a surgeon.
How would they contact Dr. Perry or Dr. Kakish? How would they, or you or yourself? How would they contact you?
So, I mean, our office number is 716-859-7937.
One more time, a little slower, please.
Of course, it's 716-859-7937. And the Dr. Kakish number is 716-898-3381. This is an ECMC.
And no matter who picks up their phone, they're going to be wonderful to talk to.
Okay. Well, we are really out of time, but I just want to let our listeners know again, our topic for this morning, the first half of this morning has been lung cancer screening, talking about lung cancer. And could you give the phone numbers if someone just got their pencil, and could you give us a phone number for someone to contact you someone to see if for a low dose CT scan? Could you just provide that number one more time, please?
Absolutely. For Dr. Kakish, that's 716-898-3381.
And for our service here in Buffalo General, it's 859-7937. 716-859-7937.
Thank you. And I just want to say we're out of time, but Dr. Perry and Megan, I just want to say you have been great this morning, and thank you so much for sharing with us. And I hate to say it, the number one cancer, the leading cause of cancer that causes the greatest amount of deaths, and that is lung cancer. And that has been our topic today, about warning signs and who to contact if you think you may have lung cancer, especially if you're smoking at least a pack or two a week, would you say, for the past 20 years?
Yes, or even more.
Yes,
yeah,
or even more. But anyway, I want to thank you both for being our guest this morning on the Great Lakes Health radio program. And don't go away, listeners. Our next half hour will be with Dr. Lisa Jane Jacobson, talking about the new curriculum for this medical school students. Thank you, Dr. Perry. Thank you, Megan, for being our guest this morning.
Thank you, Francesca.
Thank you.
Have a nice morning. Bye-bye.
You might ask, who is Kaleida Health? Because I still get that question in the community. Kaleida Health represents the hospitals being Buffalo General Medical Center, Gates Vascular Institute, Oishei Children's Hospital, DeGraff Medical Park, Millard Fillmore Suburban. We were also part of the Visiting Nursing Association, the VNA. We also have 2 long-term care facilities, one at DeGraff in North Tonawanda, and the other one in both Buffalo at the corner of High and Michigan Avenue. We have clinics for men, for women. We have specialty clinics for women who are expecting. We have family planning for targeting more of a younger audience with questions about family planning and such. We are also in schools. We have school-based health centers where we are located in the Buffalo Public School System. And we also have a great relationship with UB, the Jacobs Medical School. And I think this is probably the first time I've mentioned that relationship, because our guest for today is Dr. Lisa Jane Jacobson, and she's a professor with UB Medical School. Also, I would like to mention that Kaleida Health is hiring. If you go to our website, type in in your search engine, Kaleida Health, KALEIDAHEALTH /careers. And when you enter that into your search engine, you'll find hundreds of jobs available. Some you just need a high school diploma or a GED, and other positions require further education. But we definitely invite you to apply for a job, and please join our family at Kaleida Health. We need you. Well, our topic for today, speaking about the UB Medical School, and I think most of our listeners are aware that the University of Buffalo has had a medical school, and I'll let our guests share with us how many years. But a few years ago, the medical school moved off the Main Street campus and now located at the corner of Main and High Street. And so they're right in the middle, or at the border of the Buffalo Niagara Medical. I would say they're at the border of the Buffalo Niagara Medical Campus, because once you walk down High Street, you'll see all kinds of buildings in Carlton Street. But the medical school is there, and they're doing some very exciting things, engaging community, engaging the community to learn more about their health and to be comfortable with their primary, for you to be comfortable with your primary healthcare physician. So I'm going to introduce our guest, and our guest for today is Dr. Lisa Jane Jacobson. Dr. Lisa Jane Jacobson, how are you?
I am doing great. And thanks for the invitation to come talk with you today, Francesca, to talk with your listeners.
Thank you. And Dr. Jacobson, not only is she a physician, she also has her master's in public health. She is also the Associate Dean for Medical Curriculum in the Office of Medical Curriculum at UB Medical School, along with Associate Professor and Vice Chair for the Education Department of Obstetricians and Gynecology, which are a couple different areas we could talk about. However, today we are talking about the UB Jacobs Medical School, their new curriculum, which is an exciting topic. So Dr. Jacobson, can you just share a brief history about UB Medical School? And besides providing medical services, has the medical school always had a relationship with the community?
Sure. I actually came to Buffalo about 7.5 years ago now. So I haven't been here for decades, but the university has had a medical school since, well, before it was a university, right? Back in 47, I think, when they started the school, and it was right next to Buffalo General, where that was its location way back when. And then about 100 years later, it moved down to what we call the South Campus, with all those the other health profession schools were all centered around there too, on that Main Street campus that you had mentioned. And it wasn't until just very recently in 2017 that we moved here to the downtown campus location, and that large, tall building that everyone has probably seen got built. And it's a beautiful building with a huge atrium. If you have not been there, we would love our community to actually visit and see what this, and be part of this school, and come in and come to some of the activities we offer. But it is a really nice facility. And the reason that they built it was, well, the old facility was getting a little too old, and we needed more updated, a place for students and faculty and all the researchers who are doing research in medicine. And so we also wanted to be near the hospitals so that it could become a real hospital, a community, an academic healthcare, community. We'd be close to the Kaleida facilities, and our students and our faculty could go back and forth and easily go from the school to the hospitals, et cetera. And all work together a little bit more closely. It made it easier to collaborate.
Has a medical school always had a relationship with the community before moving into the community?
So I can't speak to all of the decades, past, but you and I talked recently about it was about 40 years ago when Dr. Maggie Wright had, who was a previous associate dean for student affairs at the medical school, had developed a program where they were teaching medical students about the importance of, working in the community, understanding the health problems of the community and issues related to equity. And I'd have to say that legacy has absolutely continued. And it's probably, I think, the strongest it's ever been right now at the school, because we've had programs that have been similar. And I'm sure her programming led to this course that we have called Health in the Neighborhood, where students actually work in the community and learn with families. They have host families, and they learn about health issues with the community, in the community. But and they learn how to do their physical exam and all of that stuff by training by people who work in the community. They anyway, those kind of programmings has been around for a bit, but now everything is expanding. And we realized that some of these programs really needed to be further emphasized. And our new curriculum that we've been developing is going to be working very hard to make some of these, to work on some of the issues that are, troubling our community and impact the health of the people here in Buffalo. Our curriculum is going to address it directly.
And I remember a few years ago, being part of the community, working along with you, maybe that's when we met, at the meeting where you were asking community about the curriculum, and you were explaining to many of us different who worked at the time, worked in hospitals or not-for-profits, what would a curriculum look like? So could you tell us, how has a curriculum changed? What was it? And what's the new?
Well, as part of the new curriculum, we realized, everybody I'm sure out there can imagine that, doctors need to know about science and understand why diseases happen. And they have to learn about treatments and procedures and medicines that have to be, given to help treat things. But what a huge part of medicine is understanding people, right? And understanding the people that, we treat. The understanding people's perspectives on their own health and what they want for treatment, everything from barriers that might prevent them from being able to even come in for care or do some of the treatment options that we kind of discuss with them. And understanding all that is really important. And as well as understanding the health system and how doctors are going to be playing a role in the health system, and how patients, how does the health system affect whether they can even get care? So those are things that we've infused into the curriculum now, because everyone needs to be able to know that and learn that. So, one of the things that's really important, we have what we call a thread that will kind of go throughout the entire curriculum, the 4 years of medical school. But it was actually started with the leadership of the late Dr. Jonathan Daniels, who was a beloved human being, physician in our community, and many may know him or know of him.
Yes, he was a great man.
A tremendous man. And he passed away about 1.5 years ago. But he started the Muse curriculum with a wonderful team of collaborators, and they're working extremely hard to make sure that legacy stays alive and that this program will flourish in the new curriculum. But it's the Muse program. He was a muse for everyone, right? He was a inspiration, somebody who made everyone, it was a thought leader. And that's sort of what I think a muse is, somebody who inspires others. And it stood for medicine, understanding, social equity. And that curriculum is being developed, and it's part of this anti-racism and health equity thread that will be running throughout the whole curriculum. So students who come in from the very first course that they take in the first few weeks are going to be understanding and learning about some of the things that impact people's health care here in Buffalo, including social structural determinants of health that, get in the way of people being able to be as healthy as they should be and obtain the care that they want to and even trust the system of care and how how it impacts them and how they interact with the system that we the healthcare system in general. So that's one example. And you asked about how do we get involved in the community? Well, we will be implementing something called learning communities, and every Wednesday or every other Wednesday, our learning communities groups, which are smaller groups out of the 180 students, they're going to be groups of 6 with a mentor. They're going to be actually going out into the community and doing something called Community Connect, where they're going to be working in organizations for every other Wednesday afternoon here in the Buffalo area, in order to sort of understand more about our community, understand some of these organizations and what they do to help people in the community, and actually getting a chance to get to know people as human beings, so that when they see them as patients, they have a connection. They understand a little bit more. Their world has been widened about how people live, and what our community is like. So that Community Connect program is important to us too.
And Dr. Jacobson, along those lines, and I know you said that the students are going out to the community, and I'm sure everything's in place. But have you ever thought about having a couple of the groups held in the med school? Because UB Medical School is always such a mystery. It's like only smart people, if you're good at math and science, go in that building. So I don't know if you've ever thought about hosting a couple of the meetings at the med school, plus, encouraging people to bring their families, because it could be that start for that person who thinks it's a big mystery. It could be for that person who may want to develop an interest in science or major in medicine, because if you're going out to the community, you won't know about what's going on in the inside. And to me, it's a beautiful building and it's not a mystery.
Yes. And, I'd have to say our new dean, she's been now with us a year and a half or 2 years, even maybe now almost. But she actually has made this real strong initiative to use our building, for more community events, because there's a real strong, desire to get people to come in and see what we're doing here. And again, make it so that it's not, a place that people don't feel comfortable in, or that they wonder what is inside that big, huge structure that's in their neighborhood, But, I think a lot of the programming that I see happening is with kids. So, our surgery department has a great drone STEM program where our local high schools kids are brought in, and they have their T-shirts made, and they compete doing surgical skills and using laparoscopic instruments. And I'll tell you, those high school students are able to use laparoscopic instruments better than some residents I see training. But they learn it very quickly. It's almost like because they're so used to games and video games too with their hands, but they pick it up so fast. And they also learn how to steer drones around. And it's basically a program that helps kids who are interested in science and technology, engineering, careers, healthcare. They kind of it inspires them. So that's one of the programs, but they also bring students in for something called Camp Cardio, where there's a week-long camp to learn about heart health. So there are a bunch of different programs that occur, mostly with bringing children in. The Girl Scouts, they bring the Girl Scouts in too to work with them during the year. But I bet more adult programming would be useful. I think it's a wonderful, wonderful idea.
Yeah. Now, when they go out into the Community Connect, and I just have to mention Dr. Daniels. Just when you mentioned Dr. Daniels' name, I still get a little teary-eyed, but because he was such a great man, and his family, they're great. But okay, so with Community Connect and going out and meeting with the community, and I know it's the medical students interacting with community. Do they also, by chance, as part of this new curriculum, speak with community about being comfortable with speaking with their physician? Meaning, do they even teach them medical jargon so that they understand? A lot of times a physician will speak to you. You don't necessarily understand, but you don't want to admit that you don't know what the vocabulary is. And do they interact with the community and helping them develop a comfort level in speaking with a physician?
That's an important goal for sure. And hopefully some programs like Community Connect will make people, just having conversations makes you understand, the best ways to converse and the best ways to explain things and talk with folks and understand them better. So I think that kind of experience will translate. They'll bring that into the, outpatient clinic or the exam room when a person comes in. They'll kind of have they'll be more comfortable talking to folks in language that people understand. And I know that you and I, as we spoke, it's been a year or more, with various community groups, and Dr. Mecca, who has been leading this curriculum revision with me, was involved very intimately in doing a lot of this outreach. One of the main topics was always, the relationship between people out there in the community and the doctors and the healthcare providers, and some of the things that made it hard for folks to come in and feel comfortable coming in to get care. And also some of those, those barriers of, well, I can't necessarily understand what they're saying. They don't quite get me. They don't understand what's feasible for me, what the life I live, and why I can or can't do what they're telling me to do, that would be good for my health. And then, just like you said, speaking in language that normal people, not medically trained people, can understand is really important. Because if somebody leaves, the office and doesn't understand what happened and doesn't understand what's going on with their health, and they can't be a part of their own, their own care. Like they want, I'm sure patients want to do their part of it in the process too. But if they have to understand it. And then a plan that makes sense to both sides has to be created, right? It has to be good for the patient and the provider. In order for it to work. So yeah, we do stress that. It's actually part of that Muse curriculum that I mentioned, that, learning how to address folks and in a way that's, understandable. And in our foundations of patient-centered care, where our students are going to learn about how to take medical histories and such things, that will be very much stressed. That whole communication aspect will be really emphasized.
And then even just making sure the patient understands why that medical history is important, because some things you go into and it's routine, but does someone know that if they've gained a lot of weight, or if they've lost a lot of weight, or if their blood pressure is high, what disease it could possibly lead to? So, it's not a matter of, again, that one-way communication. It's just trying to have that, having that individual, that the community understand why keeping their body, not to say keeping it in good shape or maintaining, but going to your provider is like tuning your car. Like, you don't go 10 years without taking your car in for an oil change, and you shouldn't, So just so they begin to understand their own importance, why good health is important. But I think that's great. The Muse, medicine, understanding social equity, and social determinants of health. I call it many times social determinants of life, because many times you can't separate one from the other. What else would you like to share with us about the new curriculum?
Oh, well, there's so many things, but I think I've we had to revise the curriculum. We were making big changes because, you know, the world moves on and life changes, world changes, and health problems change. And so we're incorporating a lot of these things too, and trying to address the very, you know, the wonderfully diverse population that we have now in this world, and especially here in our community in Buffalo. We need to make sure our students are coming away really knowledgeable about what are those things that affect our community in particular, but and beyond. So from the very first, you know, 3 weeks of school, they're going to be learning, you know, about 5 real significant societal problems that are affecting us here. And but what we'll be doing is, you know, doing it in a slightly different way than in decades past. I mean, understanding in a holistic way what kind of things, it's not just the basic science behind it. It's not just the medical treatments of how to, you know, fix things, but what are those other humanistic aspects that kind of, you know, affect people's health and affect whether they can get health care and be treated well and improve their health. And then we mentioned health system science, and also even things like how do people understand information that's out there, and what do you trust and what do you not trust? You know, when it comes to medical information, and we call that scientific literacy and inquiry. So we want our students to kind of understand how do you figure out what's really good information and what's not. And these are some of these pillars that we're kind of infusing into the curriculum so that they understand that it's not just understanding science and treatments, it's also understanding people that will make them a good doctor. Because if you don't have that, nobody's going to come to your office, and you're not going to be able to achieve the outcomes that you want to achieve, which is improving people's health. So that's really an important component of our new curriculum.
Yeah, and I know that we only have about 2 minutes left, but that's what caught my eye, that scientific literacy and inquiry, because when I saw that, it just reminded me of culturally why sometimes African Americans can be, you know, don't necessarily trust medical community with some of the different studies, and not only Tuskegee, we hear about that, but the Lacks woman, what I can't think of her first name, but I know Lacks.
Henrietta. Yeah.
Henrietta Lacks, you know, and just so not people, but the students understand that, and they don't just say, oh, well, that was a long time ago, but no, it did happen a long time ago, but that distrust is still there. So at least listening to the patient, understanding that, to build trust, because to me, it's all about building trust with your primary care doctor, and the doctor building trust with their patient. Yeah. So, any closing comments? Because can you believe we're almost at the end? Any closing comments?
That will go so quickly. Just that we would love to share our school, our curriculum, our students with this community. And we are so thankful that the community has begun to embrace our students as well, and allowing them to come into their organizations and learn. I think 75% of our doctors here in this area trained at one point at UB, whether it's in the medical school or in the residency. So those are the folks that are providing healthcare to us all. So we want to make sure that we're doing it right, and that we are developing, you know, a training program, a curriculum here, and medical school training that will provide the best, you know, graduate the best doctors who will be able to provide care for this community going forward for the decades to come. So anyway, those are our efforts, and we would love any community help people who want to get involved. There are many different ways to do that. So anyway, thank you so much for allowing us to talk today.
You're welcome. And how would they get involved? Do you have a phone number or email address?
Yeah. If they are honestly interested in figuring out ways, they can reach me by my email, even directly, ljacobs@buffalo.edu. And we'd be happy to figure out how we could get people involved.
Okay. Well, thank you so much, Dr. Jacobson, and who also teaches aerobics. I had to throw that in.
We believe in health and wellness, so.
Yes, yes.
And you were a great participant, Francesca.
Yes.
Enjoyed having you in class.
Thank you so much. And I just want to say, listeners, in 2 weeks, or I should say next week, you will be hearing from my esteemed colleague from ECMC, and that is Mrs. Bass. And in 2 weeks, God be willing, you'll be hearing from me, Francesca Messiah, Manager, Workforce Development, Kaleida Health. And I hope you've enjoyed listening to our program today, because we sure have enjoyed you listening to us. Bye-bye.